It's time to get on with things. I'm going to invite Todd Gothelf up to talk about syndesmotic injuries. Todd's been with our practice for 10 years now. He does have an American accent. We haven't been able to eradicate that, but hopefully you'll be able to understand him anyway. Todd is a shoulder and foot and ankle surgeon who has public and private appointments, and he's going to take us through the first lecture. So welcome, Todd.
Everyone can hear me? Okay, thanks, Duran. Thanks, Catherine, for organizing. So John Negreen and I are given the task to update you on sports injuries. And so mine's going to be on syndesmosis, and I think John's is on Liz Frank's. So basically my goal of this talk today is to talk to you about kind of how to recognize a syndesmosis injury, what to look for, and give you a bit of an update on how we treat them, because there is a bit of controversy around how we treat certain ones. So if you look at the epidemiology, about 1 to 18% of all ankle sprains might be syndesmosis injuries. The lateral ankle sprain is far more common than the syndesmosis injury, so those are the ones you'll mostly be seeing. Now, what is the syndesmosis? If you look at the syndesmosis, it's what connects the fibula to the tibia and keeps the two bones together. So there's most important structures are the AITFL, which is the anterior inferior tib fib ligament. And that's the first one that usually gets ruptured when the ankle twists in an external rotation injury. The posterior inferior tib fib ligament is the PITFL. And then up here we have the interosseous ligament and the interosseous membrane that holds the two aspects together. So if you keep those in mind, you'll see that when you're doing your physical exam, this is where you palpate to find tenderness after an ankle sprain. So it's an external rotation injury that usually causes a syndesmosis sprain. So you can see that the first ligament to be stretched is the AITFL, and then the PITFL, and notice that when this happens, also the deltoid ligament gets injured. And then when you see a lateral ankle sprain, it's a completely different mechanism usually. This is an inversion injury, and usually what's injured is the anterior talofibular ligament, the one from the fibula to the talus, and the calcaneofibular ligament, the CFL. So those are the two that get injured. You can see in this image that the deltoid doesn't get injured, and the syndesmosis between the two bones usually doesn't get injured as well. Here's a video. Is it working? There's no sound, but that's fine. If you watch in the middle here, you can see in slow motion, there's the nice external rotation mechanism of the injury. So this type of injury we've classified them into 3 stages. So classification 1 means that there's pretty much no instability and the ligaments were mostly stretched but not ruptured. Type 2 is when there's some instability. Usually you'll see this on dynamic radiographs, but not on static radiographs. And type 3s are frank instability, where you'll see gross instability of the ankle. Now, it's important to understand when you're looking at x-rays what to really look for to determine whether something's unstable or not. So when you look at an ankle x-ray, usually we'll get an AP, lateral, and oblique. And the oblique x-ray is what we're looking at, or the mortise view. And when you get this view, you'll see a gap in between, my arrow's trying to show you that, a gap in between, a space in between and around the talus. And that gap should be equal all the way around. The medial clear space is important to look at, and this usually should be less than 5 millimeters. You'll usually look for overlap between the tibia and the fibula. This would be a few millimeters overlap. And in between, in the tib-fib clear space, also should be at less than 5 millimeters. And those 3 things are what we mostly look at to determine whether an ankle is unstable or stable. So with grade 1 syndesmosis sprains, it's pretty straightforward for us. You can see the medial clear space is normal. There's tib-fib overlap. and this is a normal x-ray. Any investigations you do for grade 1 and non-weight bearing or weight bearing views, they won't show any difference. And with those, we treat them with a period of immobilization. We reduce the weight bearing while it's painful, and then we do gradual rehab to get them back to going again. And when you see a grade 3, this is severe displacement. So on any investigation you do, non-weight bearing, CT, MRI, you'll see gross widening of the ankle. So notice here in this image, this is a widened tib fib. Can everyone see that? A little bit widened? So, and then also you'll see fractures there. This is fractured, but the medial, you can see the talar shift laterally. So it's generally agreed that we operate on these. We want to realign the joint and make the joint more anatomic. In the grade 2s, this is really the controversial area in syndesmosis injuries. So with these, you have what we call latent diastasis. So in a non-weight bearing x-ray, it'll be normal, but with a weight bearing x-ray, you might see a little bit of widening. And the widening in grade 2s is very different. So some people, it would be completely obvious. Others, it's very subtle. So this could be a widened medial clear space just by about 1 millimeter, and that represents a grade 2. So the treatment for these is controversial because we know that some of them do well and some don't. And we really don't know if it's best to operate on them or not to operate on them. And the dilemma is that the grade 2s do not always improve. It's hard really to assess the severity with our current imaging techniques. With x-rays, it's kind of gross and it's just a judgment of how many millimeters, and it's really difficult to determine who would benefit from surgery. So if you look at some recent literature, we do know that if you leave an ankle slightly shifted, it's going to affect the ankle and be detrimental in the future. So if there is talar displacement of greater than 2 millimeters, this results in 90% degenerative changes. And also if there's a 1 millimeter lateral shift of the talus, the joint contact area decreases by 42%. So it's quite important to make sure the ankle heals anatomically, and that's the hard part. Now, to assess any ankle injury, this is normally what I would imagine you guys might see in your rooms. A person goes to the emergency room, gets injured, they end up with the physios, and you're left looking at an ankle like this. And really, that's what you have to do, is try to determine what this person needs. What kind of injury is it? So usually there are 7 things that I usually look at in every single ankle sprain because I don't want to miss anything. And how many of you have seen an Achilles tendon missed in the emergency room, but you guys picked it up in your physio rooms? I'm sure a bunch of you have done that. I've done it myself. So you always want to palpate the Achilles tendon. Always want to palpate the midfoot, and John will tell us a lot more about that. I always palpate the deltoid ligament, giving me clues whether there's a syndesmosis sprain. The syndesmosis, or the tib-fib space going up the ankle. The perineal tendons, you can have perineal tendon subluxation as an injury, especially people like rock climbers, and you want to check for those because those can be missed. An ATFL ligament sprain is common, and that's always going to be something you just check to see if it's tender, and bony tenderness for fractures. So when I do a physical exam for my syndesmosis, the next few slides are going to talk about that. And in your handout, there's a lot of the examination techniques for syndesmosis in your handout. So point tenderness is important. Where does it hurt? If you look, you palpate the anterior talofibular ligament. It is shown that if that's tender, it's kind of less likely to have a syndesmosis sprain. Palpating the anterior inferior tib-fib ligaments further up higher on the ankle, and also the deltoid ligament, because that's more common to get injured with a syndesmosis injury. The squeeze test is where you compress the calf about mid-calf level, and if you do this and reproduce pain lower down in the ankle at the syndesmosis, that's indicative of a syndesmosis sprain. There is evidence that the higher up you have pain up the tib-fib space, the more severe the syndesmosis sprain and the longer it takes for a person to recover. But palpating up there is important to determine whether there's a syndesmosis injury. The external rotation stress tests. So the foot and ankle are held with one hand, and the upper leg stabilized with the other hand, and an external rotation force is applied. So that's the same mechanism of an injury. You're stressing the deltoid, stressing the tib-fib space, and that may reproduce pain in someone with a syndesmosis. So a crossed leg test is something recently described. So if you have a patient sitting down, you cross the leg and you put downward pressure on the knee, this squeezes the tib-fib together and might reproduce pain at the ankle, indicative of the syndesmosis injury. So we briefly touched about x-rays. So after you do your exam, you need to order some investigation. So an x-ray is important, and it's a weight-bearing x-ray that we need to get. And we often get the normal side and the abnormal side to assess what would normally look for this patient and what it would abnormally look. So again, looking for the medial clear space, the tib-fib clear space should be less than 5 millimeters. A weight-bearing x-ray is considered a dynamic test. So looking at these photos, you can see non-weight-bearing and weight-bearing, and you can see how subtle it is, but the widening of the medial clear space is seen in this x-ray. You can see that subtly there's no more overlap of the tibia and fibula and widened tib-fib clear space. MRI is also quite helpful to look at the syndesmosis. So in this images, you can see on the left side, the AI-TFL ligament is intact, and the PI-TFL ligament is intact. And if you look at the MRI here, this shows a rupture of those ligaments. So you can see all the ligaments on an MRI and see which ones are ruptured. So now that you have someone who has dynamic type 2 syndesmosis sprain, that's the controversy. We actually aren't sure what the best treatment for this is, whether it's non-operative or operative. So this article done by a group in London was done, and they tried to determine which way to go with these patients. And they grouped grade 2s into ones that were stable, they considered stable, and ones that they considered not stable. And what they did was, with the ones that were not stable, they did an arthroscopy, and then they treated them with fixation if they needed to. And the ones that they determined were stable, they treated them with a boot non-operatively. So just going to touch on what these did. So in order to determine if someone was unstable, they had a certain amount of criteria that they followed. So they did an external rotation stress test and a squeeze test. They also checked for tenderness greater than 6 centimeters above the ankle. They did an MRI, and if this showed any deltoid rupture or a rupture of the PI-TFL, remember the AI-TFL is the first to go, but if the PI-TFL goes, that'll allow the two bones to separate. And on x-ray, if it showed a widened syndesmosis. So if any of these were positive, they thought that these were type 2B or unstable, and these they determined that these should get an arthroscopy and fixation if they needed it under arthroscopy. And if they don't have any of these findings, they treated them conservatively. So when you're doing an arthroscopy, you can actually see if there's any instability. What I'm showing here, that was the AI-TFL. Right there is the tib-fib space, and in the back you can see the PI-TFL ligaments. So you can actually see if they're ruptured, and you can see and assess with stress if the tib-fib space is widened. And so with arthroscopy, it's quite sensitive to see if they're unstable. In this video here, this is a ruptured syndesmosis. So what you're seeing there is a ruptured AI-TFL. You can see all the hematoma. You can see definitely there's widening at the tib-fib space. And then it takes a little time because I'm struggling right now, but we don't like to show you those things. But anyway, I'm showing the cartilage there. The cartilage looks a little scuffed but intact. Now what I'm doing is switching. I'm putting the scope in the medial side, in the lateral side, and I'm going to assess the medial side because we want to see what the medial clear space looks like as well. So there's my shaver, which is about a 3-5 millimeter shaver, and it's easily going in that gap in between the medial malleolus and the talus. So there's definitely widening there in this patient. And this patient went on to get fixation. So in the results of this article, they had 64 grade 2s. They had 26 that were stable with 2A. They wore a boot for 3 weeks, and then they did rehab. And even with that treatment, on average, they had a 45-day return to sport. So you can see syndesmosis injuries are quite debilitating for patients. In the 38 that were considered unstable, those underwent arthroscopy, and about 36 of them were found to be unstable. So that criteria that they used to determine if they were unstable, they felt that was pretty accurate to assess which ones needed arthroscopy, which ones didn't, because the ones they saw were unstable, and they fixed them. Only 2 were found to be stable at arthroscopy, and those 2 didn't have any fixation. And these patients all took longer to get back to their sport, so they took about 65 days on average. So basically, how I treat ankle syndesmosis injuries, I do my physical exam. If those findings suggest a syndesmosis, I'll order weight-bearing x-rays of both ankles in order to look to see whether there's gross instability. I'll order an MRI as well, because sometimes it's pretty subtle and hard to see. And if it shows an AITFL and PITFL are both torn, or there's evidence of widening, then I'll proceed to arthroscopy with fixation if it looks unstable. So thank you all for listening.